All right.
Well, this is wonderful. Welcome, everybody. We are so happy to be here. This today's topic is about an interdisciplinary team and how we work, why we work, and you may have questions about how a team is formed and what a team meeting looks like and how teams work together. So we really look forward to your questions at the end. But we thought we would kick things off by talking a little bit about ourselves and what we do and why we're here. And we thought at the end it would be interesting if we ran a mock team meeting so you could sort of see how things look and how things work. So either Rob or Shahan, do you want to kick off?
Go ahead, Rob.
Oh. Thanks, Sean. Hi, everybody. My name is Rob Pivador. I'm not sure if anybody, I'm looking at the screen and there's some names I kind of know. So anyways, I am a rehab case manager. I work at RIMSO. Actually, it's my company. It's where I work. And a little bit about myself. I've been around for a while. It's been since 2001, which I've been starting to work in with people with brain injuries and traumatic, just physical injuries as well with respect to motor vehicle accidents. So it's been a while, so about 20, and after 2003, that's when I started to work in case management. And I was working at NRIO, NRS, multiple other places as well. And then after started doing private case management about 2012. So that's where my little background is with respect to things. I had a little bio, of course, that you guys could have read, so you didn't have to just look at me while I spoke, but I'm telling you pretty much everything else. One of the other biggest things that I've done is working with the Ontario Prader-Willi Syndrome Association. That's been since 1996. And I'm currently the co-chairperson for that association right now as well. In brain injury, though, it's been a lot of fun and it's been a lot of work. And my role is probably one of the centerpieces with respect to keeping us all communicated with respect to our rehab teams. So that's a little bit about where I kind of stand in the whole grand scheme of things. And I kind of try to communicate everything with everybody on the team. So, but that's me in a nutshell. So thanks for having me.
Thank you, Rob. I can go next, just on the progression on the screen. So my name's Shahan Raja. I'm a physiotherapist. I've been a physiotherapist since 2002. Most of my practice, a large part of our practice has been in head injury, and acquired brain injury. I was a rehab therapist at the Hamilton Health Sciences prior to becoming a physiotherapist. I'm fortunate to work with plenty of rehab therapists and RSWs through my career, and I quite like the integrated way, especially in brain injury, how we function as a team, which is why I think this talk that we're doing today will give everyone a bit of an example of what that's like. As a physio, I've been also a preceptor at McMaster University for master's degree students, physio students for the neuro component. Even though I work in neuro, I coach football, which is a sport that has got a lot of concussions and sees head injuries as well. And I've kind of did that just for my kids, but also to hopefully give back and try to make a difference when it comes to how children are playing sport and to try to avoid concussions. The only other a few other things that I'm involved in is the Hamilton Brain Injury Association. I've done some charities with fundraising there. There's a Hamilton Brain Injury Association race this weekend, which will be very exciting as a fundraiser as well. And really, it's been sort of my career has been around working with folks, some of the folks that are here today, and I feel like I'm very fortunate to be able to share in the stories and be part of the progress. So thank you for having me.
Thanks so much, Shahan. Let me do my little bit here. Let me just open up my. So Um, my name is Lesha Dyke. I have been an occupational therapist since 1989. I did my degree at McMaster University, and I started working there actually in the pain program. But we also did a lot of work combined with the pain program and the brain injury program there. So that's really where I got my feet wet in working with people who have brain injury. Um, and my career progressed where to the point in 1998 I opened my own practice, which I sold 2 years ago actually to Julie Geronimo. So I'm sort of working for the next couple of years with Julie just before I sort of slowly ease into retirement. But my background has been as a leader in rehabilitation and regulation, primarily in the auto sector. So people who are injured in motor vehicle accidents, a lot of them have acquired brain injuries, and some of them don't get recognized or diagnosed right away. So that's always been an interesting point to me and why I think team is so important. Other parts of my life, I was involved in teaching, and I continue to be involved with McMaster University, tutoring in the occupational therapy program, the program for faculty development, where we bring faculty in from other countries and other universities to teach them about problem-based learning. And also, I was, teaching at the DeGroote School of Medicine in a longitudinal course. And that was really interesting because it got our new doctors who were about to become doctors a little bit more sort of geared to what rehabilitation does and how they maybe um, view cases that come through emergency and maybe look at those a little bit differently. Another interesting thing that I've been involved with is the Canadian Home Builders Association Home Adaptive Council, which was founded in order to really look at how we can adapt homes for a population that is aging, but not just aging, populations that have physical and cognitive disabilities. And I think that, it was very interesting for me to highlight to these home builders that there are things that they can do or should be aware of in terms of modifying a home for brain injury, which they weren't even thinking about. So, what kind of light fixtures that you choose, and the kind of bulbs that you use, and the kind of colors that you choose, and the kind of finishes that you may use for tiles and that kind of thing. And so that was a very, very interesting thing for me to participate in, to make, a whole different sector more aware of the needs of people with brain injury. As an occupational therapist, really, I see my role as helping to develop the toolbox, if you will, after brain injury. And because we work primarily in the home, occupational therapists help to develop strategies to manage brain injury symptoms and the emotional fallout of a brain injury better. So we're often on the ground and see things um, maybe first, or see things that people don't get to notice in the course of a clinic visit. We try to help our clients build their own toolbox, and that's, I think, a real key thing, because not every brain injury is the same, and so every program has to be tailored to what a person's needs are. And also, it's really important to recognize that people come with their own tools, with their own set of skills and gifts. And so, what we want to do is leverage or find out what are the strengths, and leverage those so people have an easier time through rehabilitation. Working in a team, for me, like I said, I feel a lot like OTs are the eyes and the ears in the home, and we see how the client is coping alone, but also within the family unit. Um, I want to ensure, as an occupational therapist, that the home is a place where the clients feel safe and they can function well. And I want to also help our clients understand how to work within the symptoms that they have so they can have strategies in place when the symptoms of brain injury interfere with daily living activities. And the other thing that we do is help to reinforce all the other strategies that are being taught in a clinic setting. So if our clients have been given uh, exercises by physio to do at home, we make sure that those are integrated into our weekly planning, diary where people are looking to see how they can integrate all of their activities into a week, or speech language pathology or whatever it is. So that's basically where we come in. So what I thought I would do at this point is talk a little bit about a client that is sort of loosely based on one of the clients that I've been dealing with. And Shahan and Rob and I are going to conduct after this a mock team meeting. So you have a bit of a sense about how we function as a team, and so bear with us. So the client that we're going to talk about today is Jerry, and he's a 45-year-old accountant. And Jerry liked to go for a walk in downtown St. Catharines at lunchtime, and he was hit as a pedestrian while walking on the street close to work. He had a fractured leg immediately, and was knocked unconscious for at least an hour. So he was, rushed to hospital. He was assessed, treated for TBI, and as he was, knocked unconscious for almost an hour, and had to undergo a surgical repair of his leg. Because he had purchased additional benefits through his auto insurance, he had access to case manager. So occupational therapy was involved quite early. Um, Jerry had contacted a lawyer, and the occupational therapist was referred to help with hospital discharge and to assist with any home modifications that needed to be made for Jerry once he was at home. So obviously we needed to make sure that Jerry could get into his house safely, had a use of a bathroom that was accessible to him, both on the first floor, but also where he was going to sleep. And we determined that he was able to make it up the stairs to his bedroom. So the bedroom was going to be in use, therefore the bathroom had to be modified. And we also had to start thinking about making sure that we had attendant care um, because his wife worked full time, so we needed somebody around to help him with making meals during the day and that kind of thing. So that was sort of the initial part. But very soon we needed to ensure that there was other referrals happening. So the case manager was put on the file. And at that point, the occupational therapist was, going to be working with the case manager to say, let's figure out what this plan is, what the rehab plan is going to look like. And a referral to physiotherapy was going to be made right away because once the acute stage of that fracture was over, we really needed to work on physiotherapy to get that going. And all in due course, things looked pretty good. Jerry seemed to not be complaining a lot about any kind of issues with headache or brain injury symptoms. But then again, he was at home and he was in a quiet environment, and he was in not doing a lot of um, calculations or the work that an accountant generally does, which is very, very, cognitively demanding. Um, and he really wanted to get back to work as soon as possible. So OT did a work assessment, and we sort of transitioned from, working from home, answering emails to working in his office initially, part-time, and we were trying to build to full-time hours. But we found that very quickly that his difficulty with concentration and headaches really started to come more to the fore. And he had difficulty with memory, and especially with verbal memory. And some of his staff, especially his assistant, was noticing that she would say something to him, pop her head in, say something to him about a phone call or something that needed to be done. And as soon as she left, that was gone. And so he needed to be reminded a couple of times. And so, based on that concern, um, that was brought to case management. And also, in one of the visits at home, the um, uh, his wife was saying, Jerry's now walking for fitness on the Niagara Escarpment, and he's fallen a couple of times. And Jerry was like, no, 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 it's fine. That was just a slip, and the ground was a little bit muddy and whatever. But she said, no, like, really, Jerry, you have a hard time. I noticed even on uneven ground around, our property. And so again, that was a sort of a heads up. Maybe we need to look at sort of vestibular functioning and how balance is working. So a re-referral was made to physiotherapy. So at this point, we are going to take it away and make it a case management um, meeting, or sorry, a team meeting that the case manager has called together.
So thank you very much, Lester, for all of that information, for the breakdown of the case study that we're going to be doing. I think it gives you a little bit. We had a lot of forms and stuff that we were going to show you guys, and it would have been a little bit all in front of you, and you could have been reading off the screen as well. I have a couple of things. We're just going to come back to our team meeting that we had that we're going to be doing at near the end, just to kind of give you a little bit of that scenario. But even before we get into that, just talking about collaboration and teamwork here that we did. Just even presenting this presentation for you guys today, it was a lot of all of us, myself and Shahan, who I worked with Shahan before, but it was the first time being with Lester about this time. So it was so great to speak with you and to kind of get to know you, and now trying to formulate something to present to everybody. So we, through a lot of our emails and communications and our own little meetings, that's what we ended up doing in order to tie in together what we're going to present with you guys today. And one of the things was to do a case study, but even to talk about different ways that we've all had success in trying to, in our own roles as case manager, OT, and physiotherapy, work together collaboratively to help with our clients that we work with all the time. One of the things that as a case manager I've often done is whenever I'm meeting with someone, I present with them a little form that kind of reviews all the different roles of what a case manager does. And what I often do is review that with the client, just so that they know where to go and when they're coming to me, and what I'm supposed to be explaining, or what my role is in the whole grand scheme of it, because there's so many members. And usually with our clients, as they have severe injuries, it's a large team. So there's a lot of team members. So just even define that and give them a center point to someone to come to. And so with that, they can, relay information to me that I can go back to each of the team members or direct them to where to go. And even at the same time, give heads up to the team members as to the client's needs or what's happening with them as well, right? So that everyone is informed and knows what the next steps are or what things are kind of happening. So as we were looking at this case study, we thought we kind of talk a bit about we use our team meeting, our mock team meeting, to kind of give you that example as well. A couple of the other, but just to give you some other parts as opposed to just the team meeting that we would be doing if it was virtual. Well, now we do them virtually as well. They used to be always coming together in person. It also depends on the client, our locations, and the time frame that's needed with respect to is it a quick thing? And now that everybody's more open to the virtual stuff, it always seems to be the best way that we like to communicate. Hence, here we are on our Zoom call today. So one of the things that I find that's really helpful is establishing also sometimes a texting communication between some members as well. So to make the group smaller, so that it's not too much information all coming at one time. So I've been relatively successful, depending on everybody's ability as well, to set up, let's say, a group little chat with, let's say, parent, and if it's their child or their spouse or whatever, and the team member that's kind of looking after a certain goal, whether it's physiotherapy goal or an occupational therapy goal or a speech therapy goal. And then after that, there becomes a little bit of a hub. So these little hubs all together allow us to make sure that we're all on the same page with respect to moving things forward for everyone. So, and it's been something of a success. Sometimes it doesn't always work, but that's one of the ways that it does work for the most part. Other things too has also been just even our email chats and conversations. So there's more of a global one with all the team members. So everybody kind of has a roundabout idea of what's going on, and after also just doing it through like, smaller groups as well. One of the other roles that I tend to kind of do is just liaise with respect to the medical side of things. So as team members like OT, PT are wanting me to go to, let's say, a medical appointment to get some information, or even communicating with the RSW who's going into that to a medical appointment, just to pass on questions that way. So it kind of eases the burden on all of us. We kind of do it all collectively with questions to go even back to the insurance company if needed, right? So, but those are kind of in a nutshell, those three ways I've been pretty successful at making sure that we're all working together and communicating back and forth and helping move goals forward with respect to each of our clients. So in a nutshell, that's case management. Shahad?
Thank you, Rob and Aisha. So I think I'll kind of start with back to Jerry. So if once physio, I was to get that referral from physio, I would speak to the OT and speak to the case manager and say, okay, just are we going to be seeing this client in their home, or are we going to be seeing them in the clinic? So somebody like Jerry, we would have them come into our clinic in St. Catharines on Hartsel Road. And I would talk to the OT and the case manager to say, like, so is this a person that needs our help to come in? We've had situations where clients come through in wheelchairs, in various taxi cabs, and sometimes we have to go out and get them and help them in because they're in wheelchairs. So we would, right off the bat, I would try to figure out from a transportation standpoint, is that has been set up, making sure that they can get there, and then I would get that information from OT to say, okay, yeah, their balance is not great, but they're ambulatory, so you don't have to worry as much. Versus it's quite compromised, so make sure you look out for them and help them in. You might need to help them into the clinic in a wheelchair. So, well, as soon as we figure all those logistical things out, with someone like Jerry, just to go back from the history, as we talked about, Jerry had a lot of orthopedic injuries and some of this brain injury, and potentially vestibular issues, which is, for those of you who may not be familiar, it's a system in your inner ear that helps you control and regulate your balance. So if that system has been somehow affected, it would play into why Jerry might be tripping and falling. Now, Jerry's a very interesting case because when we find, like with our head injury patients, when you've had an orthopedic injury, sometimes the balance will be compromised, and it's really difficult to tell whether that's because of your vestibular system, your head injury, or the broken leg. So if somebody was to break their leg and the injury heals but not heals fully, that would cause a balance issue. So as a physio, especially someone working in neuro, we have to be cognizant of how those orthopedic injuries affect the person's balance, and that'll help us tease out how much of it is orthopedic and how much it might be head injury related and how much it might be vestibular. So with someone like Jerry, we would have Jerry come into our clinic, and start with doing a comprehensive assessment. And that assessment, from a physio standpoint, we would look at some of those orthopedic injuries and look at range and say, has this orthopedic injury fully healed, or has it only healed partially, and the patient has made some adaptations, or Jerry's kind of figured out ways to do things. It's not ideal, but it's working for Jerry. But as Elisha is saying, when Jerry's out doing things in the community, going back into the escarpment, then Jerry's pushed, that's when the failure is happening. So we would start by, like I said, looking at the orthopedic injury, making sure it's fully healed, and then taking a look at a balance assessment. And what that would mean is that we would take a look. I get into sort of different balance tests and stuff that we use, but the bottom line is it's a test that would allow us to say, okay, how is Jerry functioning for Jerry's age, a 45-year-old? What does that compare to other 45-year-olds in our community who have not sustained injuries? Where should Jerry's score be? So that will give us a good idea. And that's something we could share with OT to say, listen, like Jerry's scoring at 30% of what he should be. Like maybe, we got to take a look at some of the community stuff that Jerry's doing and saying, is it safe to do so? We would share that information with OT. We would share it with case manager, and the family as well, to say like we're somewhat concerned. Jerry might be hiding the balance really well, but we're somewhat concerned when he might be on one leg, for example. So our balance test would tease some of this stuff out, and we would be able to give the team a better idea of where those deficits are coming from. Once we've gotten through that, we would take a look at things from essentially a vestibular standpoint. So when I hear headaches, uh, difficulty with balance, one of the things we want to take a look at is whether the vestibular system, which is a system in your inner ear, have on both sides, is that working properly? So essentially how the vestibular system works, just a quick breakdown, is it takes information from our eyes, our proprioception, so sensors through our body, and essentially and of course our vestibular system itself, and it sends that information to the brain, and the brain tries to figure out, okay, is all three of those systems, are they working properly? So we'll take a look at those three systems to see if they're working properly, and if they're not, we would try to address them, and that there's a vestibular therapy for that, and exercises and so forth, that again we can share to the team members. If there's an RSW on board, we can share that to the RSW. Or it could be that all three of those systems are actually working really well, but the brain, due to a head injury, is actually not putting that information together. And that's something that we can sort of screen. So, there's levels. So as from a physio standpoint, we can screen for some of this stuff. As it gets into the more the brain injury component, we can again talk to the team, talk to someone like Rob, talk to someone like Aisha to say, listen, could we then facilitate even a further referral to potentially ENT, who are specialists that look at vestibular systems, a little bit, actually a lot more in detail than physios and OTs would do. And then also potentially from a neurology standpoint, like, is this stuff actually from the brain and not from the vestibular system at all? So, being able to have somebody that sees the patient regularly in the home pick these things up, allows us to assess it and see if we can treat it. And if we can't treat it, then we would then talk to the team and say, like, maybe we need some further referrals to help this patient out. So in Jerry's case, going along with our case study, we are able to treat his vestibular symptoms, but we still have some balance issues that we're concerned with. So we don't want Jerry, quality of life. It's really important for Jerry to go out on those walks that he enjoys so much, and we don't want to take away from that functionally, because I think it's good for his quality of life. So for us, we're saying, okay, while we continue to treat Jerry, maybe Jerry could benefit from some walking poles to when he's walking. So he'll have not just his legs, but also two poles to be able to stabilize himself. And that way we're not as concerned with injury while we're rehabilitating. So in that case, we just go back to the team, let the team know that this is what we're suggesting. OT can definitely do a treatment plan for that, and arrange for funding. And then we have sort of a short-term plan on how we're going to help Jerry. And if things don't improve, then we have a long-term plan. We go back to the team and say, listen, we got to see a specialist at this point because this stuff doesn't seem to be clearing up. So,
I think
okay, so that's sort of how it would be for us.
I think this is really great because before we go into the mock team meeting, I just want to make this point that people sometimes think that rehabilitation is a straight line up, and often that is not the case. And one of the things about this case with Jerry that we wanted to highlight is the fact that um, things revealed themselves over time. And so sometimes that happens. And so it may not be a new thing. It may be something that has been there, but the environment hasn't challenged that individual. And now that the environment, whether it's work, whether it's hiking on the escarpment, whether that has changed, and now it's challenged somebody, and we're seeing things that we didn't see before. And so sometimes people think that, oh my gosh, this is a new thing. Sometimes it's very frustrating because insurance adjusters sometimes think, well, that wasn't an issue before. Why is it an issue now? But this is the reality of rehabilitation, is that we are finding things out, and things are evolving as that environment changes. So in Jerry's case, and we want to talk about that a little bit today, I want to let Rob take over. But he's back at work and not progressing, and we're needing to figure out, you know, why Jerry, who initially said that he was doing well and he was fine, um, and just a little bit of background there. He was very, very anxious to get back to his accounting job and, ensure that he was really wishing that everything was going to be okay. So he was sort of underreporting. And now that we're into it and we're seeing difficulties happen, um, sort of some of the alarm bells are ringing, and Rob, the case manager, has been his ear to the ground with the team, and he wants to see what we can do. So, Rob, why don't you take this away?
Yeah, so after we've all done our text messages communicating assessments and everything, and we've made our referrals out to everybody after we've started this whole, looking at this issue with respect to the falls and now putting it all together. Typically, what would happen is I'd sit back and I'd be like, hey, maybe we need to have a team meeting with the family and with all of us all together and kind of collaboratively talk about where we're going to go from here. So, set up a date and go for that. I could tell you right now, setting up a date with any team takes it like it's a mountain, but we do it and we make that get there to get that date. But as we all know, it's always a bit of a struggle. Again, we have to be very happy that these virtual meetings are available, so it allows us to shorten that time frame as we could squeeze time in. So that we get our date set up. If the family's involved, sometimes it all depends. But at this point, we're going to have the family involved because they do have some input, and we want to make sure that we're sharing with them as well. So I'll set up. Usually, what I would do is I kind of have a little bit of an agenda that I would pop up and send to everybody just to keep us on track, following through with what the goals of the meeting is going to be. So we set it up for today. We'd start off the meeting typically with a little bit of an introduction, going over where everybody is, if anybody needs to be here, if there's any new team members at all. And after from there, a little bit of a general update as to where we are. I usually kind of little summarize everything of where Jerry has been, what's been going on from my perspective, what kind of medical appointments have happened from there, just a general overview. And then after bring it into whatever the topic is, which we were talking about Jerry and his falls and his less progress in some of his rehab goals. And then from there, I would sit back and I'd ask the occupational therapist and the physiotherapist to provide little updates that they have. So this is where I would lead it off to them and start off with an OT update and a PT update, which we kind of already did them separately on some things here. So we won't need to repeat that part. If there's anything else I'm missing as well, that's you guys jump in, please. And then after from there, it becomes an open discussion. And our open discussion is where I guess we can start off from at this point in time talking about Jerry and our findings and what we think we can do. So I don't know if it's physio or OT who wants to kind of talk this open discussion up with where we would be at this point of our team meeting.
So I can start. So I think what I would do is just based on our assessment, share with both OT and case manager that there are some concerns that we found through our assessment, and that the balance is sort of not where we would want it to be, and that there would be some functional limitations as a result. So, what can we do to try to negate these risks of falls? What is our short-term plan going to be, and then what's our long-term plan going to be, and what we're comfortable with. So the couple of things for me would be, from an OT standpoint, is there any type of adaptation we could make? We've got a couple of suggestions for that, like using walking poles to help with at least some stability. And then, for me also, there's some concerns from a case manager standpoint. Do we start facilitating a referral? Rob, do you contact a family doctor and do you say, listen, like there's some stuff there that physio's finding, and can we start a referral to ENT or neurology, just to make sure that we've covered our bases?
All right. So from an OT standpoint, I would be sharing something along the lines of this, is that um Robin, we started talking about return to work, and that was a big goal for Jerry. Jerry's an accountant. He is his job is one that's important, as he is a partner in his accounting firm. And so for him, he needed to get back to work and assume his role. And he, I think, found that he wasn't having too many issues while he was working from home. Again, we were on one way happy to see that, but we also were aware that when he was working from home, it was in a quiet environment. He didn't have a lot of other, noises or any kind of distractions in the background, and his work had been really limited, to answering emails and maybe reviewing some documents, but he really wasn't doing some of the hard core accounting where he was sort of multitasking. So, when we did this return to work program, Rob, we tried to ease him in. And I think that we got him to that half day point rather comfortably. We were working on managing some symptoms, but as soon as we increased that, that's where I think we started seeing more and more problems. And I think it was both increasing time, but also some of the work tasks increased and some of the expectations from his team increased. And one of the things that, in my meetings with his management, um, that came back to me as a concern was the fact that um, he's forgetting things, and he's forgetting things generally when they are told to him verbally. And so even though we have a strategy in place for him to take notes and so on, sometimes he's not in a place or a position where he can easily take notes, or he's reminded to take notes. So I think that we may need to sort of circle back and look at those job tasks and try to figure out how we can help him, number one, manage the symptoms because the symptoms have increased, and number two, deal with some of these issues. So, um, Rob, I wanted to just pick your brain and see if we could maybe come up with some ideas.
So if we're looking at both of the issues, that typically this would be where the conversation would come out. I would be going back to the falls as well as the return to work and kind of trying to tie them in a little bit, asking everybody, kind of saying, it sounds like as we're increasing Jerry's extra roles, it's actually having an impact on some of his recreational stuff that he enjoys to do as well. So maybe the ENT referral is might be not at this point needed yet, but we might need to refocus and to kind of see if by lessening some of his work stuff needs to happen, or the return to work strategies, kind of lessen that to see how they might impact on our with respect to physio activity, the recreational stuff, especially walking on the escarpment and stuff like that, and the falls that have been kind of increasingly happen. So there seems to be a bit of something happening in here that we need to kind of isolate a little bit more, because it sounds like from when physio was working with them, things were kind of getting better and improving. And then after this started happening, and then after we started increasing the work stuff. So maybe as a team, if we start there and we start kind of decreasing that, and now and physio keeps monitoring to see where things are, and after we ask the family and the RSW, if he's going with the RSW, which I'm not too sure, walking in might be on his own or which is with his wife, but just to give us more feedback as to have things kind of decreased as we pulled back on some of the activities that he's doing at work. So maybe that's Does that, as a team, does that work for everybody?
Yeah, and I also was thinking, Rob, what are your thoughts about referral to speech language pathology? Because I'm quite concerned now that we're seeing some deficits that are really in that verbal sphere,
Right.
and verbal memory, and maybe we need to kind of tease that out so we can really tailor his approach to work in a way that will make sure that he's not letting stuff go or forgetting stuff, because really the risk is if he is not performing to a certain level, that's going to be a risk to him. So, wanted your thoughts on that.
Yeah, it sounds like a great idea. I think, yeah, no problem. I can do the referral to for SLP, looking into those goals specifically. Um, Do we think at all that there needs to be anybody? I can't remember. I don't know. We don't have anybody of a rehab support worker going in right now, or any type of job coaching, or anybody doing any monitoring. Do we feel that that needs to be at all added in, or are we okay just to have the speech therapist come in to do some stuff with respect to just isolating some tasks?
Maybe we just do the speech language assessment first, see where that shakes out. But I like the job coaching model. If Jerry's open to that,
Mhm.
I think that's a great way to ensure that all of those strategies that we've put in place already, but maybe new ones that speech language may have, that he is supported in implementing them. Because I think that that's also um, sort of falling through the cracks. I think he's relying on his, um, you know, sort of his old ways of doing things, and
Mhm.
hoping that it's going to, be good enough, and the strategies are going to work. But clearly they're not, and so we need to really work on coaching and making sure that those new strategies stick.
Is there anything from a physio perspective that you think might be important to add into any of the, maybe not the work stuff, but on the other side of things with respect to other um, strategies to help with respect to the falling and stuff like that on the walks, Sean?
Yeah, so I think a couple of things. I think it's very helpful, the information that we would get from speech, for example, at least an assessment, because maybe that will affect how we communicate. So we have given Jerry homework to do. It, are we giving it in the right platform? Like, is it verbal stuff obviously is not working for him. Are pictures better? We can send videos. So how do we break it down? What's the best communication strategy where we can know that consistently monitor that he's understanding the exercises and able to do it properly. And of course, if that doesn't work, if there is some help at home, so that'll be very helpful for us from a speech standpoint and how to communicate with Jerry. We can also share that if we, from what we can see so far, we're going to monitor this, but we can see so far, if some of this balance issues are coming from a head injury, the balance itself is going to be an underlying factor. So if it is going to take more concentration and more cognitive um, abilities for him to be able to do tasks and monitor his balance at the same time. So that is going to play a role. So if at work he's having to take on a lot, when he first gets up out of his chair or has to change positions or has to leave at the end of the day, he may have a hard time with his balance at that point, because it's going to take a lot of brain power to manage your balance, especially when there's an injury. So that's just something from a physio standpoint that we can contribute to that.
So typically with all of this information, because I think I know we wanted a bit of a question and answer period, so I'm going to kind of take our little mock team meeting, and what I would usually do, I kind of was writing down notes just as if I would at any team meeting, and just kind of to wrap it up to kind of come up with, all right, so we're going to be doing a referral to SLP, have them do an assessment. We'll continue monitoring some, decreasing some of his work activities, and monitoring those as we kind of decrease them and increase them again slowly, kind of idea, and see what the SLP comes back at. RSW might be a potential, or job coaching might be another potential referral depending on the SLP outcome. We'd set up some dates, some in which to kind of come back to revisit all of this, see where things are, continue with our email communications, and go forward from there. Maybe last one I would throw in was even an RSW or using kin out in the walking situations to say maybe we can probably stick that into as he was going out there to see if there was something we're missing there, right? Then that might be something to kind of look into, unless you're already out there hiking with him, Shahan. But so yeah, so at this that's where we'd wrap up a team meeting after a certain period of time, because sometimes team meetings can go on forever, but we would have to kind of end them eventually when we come up with some type of outcome. And after we go out and communicate everything from there, and a little summary of our points and responsibilities to everybody would go out, either in an email, a formal letter, or some type of summary of the team meeting, depending on how much was coming out of that meeting as well, right? So, but yeah, so that's our mock little team meeting for everybody, and a little bit of an explanation of how we collaborate and how we collaborated to put this together for you as well. So I'm not sure, Sarah, you popped on.
I was just going to say thank you guys so much. This definitely, I think, gave us a look into how each individual role within like the ABI survivor experience can kind of come together to not just address singular goals, but really look at the whole rounded picture of the person and what they're wanting to get out of their healing journey. So thank you guys so much for that and for taking us through what a mock meeting would look like. I think that's incredibly helpful to look at all the different options. That being said, I am going to stop our recording now and open the floor for any questions that people might have for our speakers today.